So I just met with your PCMH team. PCMH is Patient-Centered Medical Home. So you've got a team now that's going to help work towards this vision. And I could talk to your director for a little bit just to get a sense of what is the long-term vision for public health and the services that you provide. And so I understand that you are moving kind of incrementally from providing some primary care services to providing more primary care services, and that you may eventually apply to become a rural health clinic, which will allow you to increase your reimbursement significantly so that you can underwrite some of your self-pay patients. I also understand that there's currently some negotiating going on with some of your commercial payers, like Blue Cross Blue Shield, so that eventually the health department would be attributed patients for whom you would take care of all their primary care needs. Is this news to anybody? Oh, okay. Okay, good. Well, it was a little bit new to me, so I was like, oh, okay, I gotta get my head around it. Usually I work with practices that are, have been providing full, primary care for a long time. They're just moving to a patient-centered medical home model. It's really great that you're doing both at the same time, because as you expand your services into primary care or more full primary care services, you're going to do it through the lens of a patient-centered medical home, which is one that is of high quality, one that's coordinated, and one that's comprehensive, it has a lot of attributes that are really positive. So, I'll hold back up in just a second, Lori. Okay, that's fine. So, I can start by introducing myself. So, I'm Lori Weisselberg. So, my background's in public health, and I'm a clinician, but I did start out as a nutritionist. I never took that RD course, and worked in the workplace. But have worked in public health departments before, New York City public health department, pretty crazy. But about 20 years ago, I started working in primary care on primary care quality improvement. I was actually working at the health department on childhood asthma, and there was a provider initiative, and I led that. And so I would do cold calls to providers, pediatricians, in hotspot areas in New York City where they had a huge number of the population of kids going to the emergency department, being hospitalized for asthma, dying from asthma, falling out on the fields when they're playing in gym. And so I'm like, what is going on in terms of diagnosis and treatment? And so we started talking to these providers, many of whom didn't know that there were national guidelines for how to treat asthma or how to diagnose asthma. These kids were completely underdiagnosed, undertreated. They were treated with nebulizers only, so they would have to miss school if they had an asthma exacerbation and it wasn't getting at the underlying, inflammation, or just getting at, kind of quick relief, the constriction stuff, and if any of you know asthma. So at that point, I said, okay, well, there are chronic conditions of public health importance, right? And so I took my public health hat and I said, I want to work in primary care improvement because they're such a big part of, what is going to allow us to better manage the population with these conditions. So anyway, so that was kind of my journey. And here I am 20 years later after working in primary care improvement in the chronic care model. Some of you probably heard about that for many years. And patient-centered medical home has been around for a while. It was actually the term was coined in the 60s, and it was around pediatric patients that had special needs. So I have two kids with special needs, and I know that to keep their lives coordinated in terms of what therapies they need, what medications they need, what specialists they need to see, is really challenging. And so that's how this was started out, to make sure that you're really putting the patient in the center, and that you are caring for all of their needs and in a coordinated way that makes sense for them. So, so it's become more and more popular, and now most primary care practices are thinking about or doing patient-centered medical home, and it makes sense for all patients. right, like throw a limb up or something.
Okay, got it.
Assume that means advance. So, so you guys know that we spend more on patients per capita than probably any other country does, and that our health outcomes aren't terrific. So how do we change that? How do we turn that ship? Well, the triple aim was coined, that term was coined in probably about 10 years ago, and what it really focuses on is the individual experience of care. That we want to have people say that, yeah, my care was really good, that I had a good experience, that the satisfaction is good. We want to say that we are improving the health of population, that we can demonstrate that on a population level that people are healthier than they were before, and that we want to keep costs in check. You know, we don't want to say, you know, we've got to, you know, really, cut costs like the HMOs early on, right? In the 80s, they were saying, well, we're not going to improve this service to keep the cost down. Well, that's absolutely not where we're at with patient centered medical home. It's making sure that people get the care that they need, but that there's not duplicative care, like you've got hospital testing them for the same thing the primary care person is testing them for, or they're having unnecessary, testing. So that kind of thing. So we're reducing costs in a way that is appropriate, right, and makes sense. So it's those three things. So the United States will not achieve high-value health care unless improvement initiatives pursue this broader system of linked goals. In the aggregate, we call those the triple A's, that are experience, that are health of population, and contain costs. And there are lots of countries that have this under control, and they're doing really well. Okay, I'm spoiling. So payment system for the care that you provide is inextricably linked with the delivery system, how you deliver care, right? So this could be new to some of you, but some of you, just graduated and could probably teach me a thing or two about this. But so one of the goals of the state of Idaho in its efforts to support patient-centered medical home are to align those things. So they're bringing together the payers, the commercial payers, Medicaid, and Medicare is doing something, but they're moving in this direction to look at how the payers can incentivize practices to provide better care, right? So so we want to align the support of public and private payers to accelerate practice transformation, to incentivize you to do the right thing. So let's move on to the next. So how is healthcare paid for? So traditionally and right now, how is healthcare paid for? Both public, meaning Medicaid and Medicare, and private payers, so your commercial insurance, Blue Cross Blue Shield, whatever, have historically paid for volume of care, right? So you get paid for every widget, right? So it's called fee for service. You get paid by the number of visits. You get paid every time someone comes in. So if there are primary care practices that will only give lab results if the patient comes in, even if they're negative. What a waste of time, right? I have to take off the book, come in, just sit there, wait in the waiting room to be told I have a negative test. Really? But that's because they get paid. That's how they get paid. The number of procedures, every procedure, is a fee. The number of services is a fee. So we want to boost those things up so that we can be as productive and as possible and get as much money as we can, right? That's how it's worked. It's not always just for the patient. Okay, let's move on to the next. So, so public and private payers are starting now to focus on value of care as opposed to just the volume, right? So you may have heard that in the ether. We're focusing on value, not volume. How do you measure the value of care? So it's those things that are related to the triple aim. So health outcomes, so population health. So if you have a group of patients that you're responsible for taking care of, you need to demonstrate that their health outcomes are good because you're accountable for all of it, even if they don't come in. So this is a new concept, right? So a health plan attributes a patient to your practice, and You are responsible for them regardless of whether they come in. It used to be, who are your patients? People come to see me. Well, now it's really who's attributed to you. You know, who signed up to be your patient. So you're responsible for their health outcomes regardless of whether they come in. So we have to get them in. We got to know who they are. We have to have a continuous relationship with them. We have to understand what's going on in their life, right? So health outcomes is one way of measuring value. And an example of that might be that of my diabetic patients, you know, 90% of them have well-managed diabetes. You know, that would be a good indicator, right? That their hemoglobin A1C might be under a certain point, you know, that they're well-managed. Okay, quality processes of care. That's another way. So quality indicators. Are you doing the things that would lead someone to have a good outcome? You know, like are you doing lab tests on them regularly to be able to monitor that they're doing well, or that you're providing the right net. The next thing is patient experience. So are your patients saying, yeah, I'm not being denied things that I know I need. I'm not being dragged in to be told that I have a negative path result, you know, that kind of thing. And appropriate utilization and costs associated with that. So, you know, in primary care practices, and again, you're moving in that direction. Some people go to the emergency room, you know, for their care. And why is that? If it's something that could be taken care of in an outpatient setting, why do people go to it? Could be that the ER can't turn them away, right? That's an Intel law. Hours, right? Access, right? So one thing is primary medical home really focuses on is access. But if you do go to the emergency department for, let's say, a headache, right? What might they do? The clinician, what are they going to do if you have a headache in the emergency department? Right, exactly. They're going to treat it like it's an emergency. They're going to do a CT scan. They're going to do all sorts of things, right? And it's going to be really expensive. But if they came to see you or another provider here and you start talking to them a little bit, you know, you realize, oh gosh, they just lost their job. They're so stressed out. You know, this is going on, that's going on. They didn't have hair growth. This is probably a stress headache. You know, what they need is blah, blah, blah. You know, and you're going to treat it really differently than an emergency department. It's going to be a lot less expensive. So, and the emergency department's not going to ask about those things. They're going to be like, get them in, let's see what they have. They might have a tumor, you know, that kind of thing. So, okay, let's move on to the next. So again, value of care. To survive and thrive in the new environment of payment, we need to focus less on volume and more on the value of care. Idaho is not quite there yet, right? So they're still paying a lot of fee-for-service. Medicaid in this state is very progressive. They're really looking, it's really state-of-the-art. They're incentivizing for primary care practices to become patient-centered medical homes, to be more accessible, to be more comprehensive, to be more coordinated, those kinds of things. And they're giving you money per patient per month, if you meet certain criteria related to value of care. And that's amazing. Medicare is doing the same thing, and I know you have some Medicare patients, probably not a whole heck of a lot, but there's this new thing called MACRA, you may have heard of, and they have quality metrics that you need to meet, and you're paid based on whether you meet those quality metrics. So at least the public payers, Medicaid and Medicare, are moving in that direction. We have to. And the commercial insurers in other states are far ahead of where they are in Idaho, but it's coming. So they're going to start paying you for meeting quality metrics, and so you're going to need to be able to produce them. And they're going to they'll probably start looking at a per member per month payment for you to take care of, primary care for everything your patient needs. And what happens if you spend more than they give you? It's just like a paycheck, right? What if you spend more than you get? You're not going to have very much money, and you're going to start going in the red, right? You're going to lose money. What happens if you figure out a way to provide primary care in the best possible way so that you're preventing people from going to the emergency department, you're preventing people from getting some chronic conditions because they're taking good provide value, like the Honda, right? A Honda's out there, so they're on the streets for decades, you know. I have a friend who has a Honda 1988 Honda, she's still driving, you know. So if you do everything that's high value and you get that per member per month thing, you're probably going to make some money, you know, because the way they set their rate is by looking at traditionally, historically, it takes about this much money to care for a patient with diabetes, for example. And let's say, okay, well, this is what we're going to pay. But if you're doing really well, there's going to be added money. You're going to have some savings there. So, so you can underwrite some of your self-pay patients. You can do other things with that money, like put it into, you know, get some electronic things that will help you manage your patients better, registry or whatever it is that you might need. So does that kind of make sense? Okay, so you see now how payment and your delivery of care is really very much linked. Okay, so where are we headed? The patient-centered medical home model of care is a framework to help us improve the value of our patient care and demonstrate that value to your patients, so that they stick with you, right? Because they have choice, especially the paying ones, right? They can go anywhere, and to your payers, so that they'll say, oh, you know, we really want our health department clinics to be in our network because they're really good, you know, and they're saving money, and we share that savings with them, and others. So that's where we're headed here. So how do we define patient-centered medical home? Well, it's best described as a model or a philosophy of primary care that has certain attributes. It's patient-centered. So we'll talk about each one of these things as we go. It's comprehensive, not meaning that you have to provide every service, but that you have to help ensure that the patient is getting everything they need. So it might be a specialist, or it might be a therapist, or it might be someone else in the community that you refer to, but that you connect with those folks and you know what's going on. You can't coordinate someone's care unless you know where they're going. That is team-based, that is accessible. So team-based, meaning that everyone's working at the top of their life, right? So, you know, we don't want Kristen rooming people and taking their blood pressures, you know, and, you know, we don't want Nancy to be doing, you know, to be rooming patients. You know, we want people to work at the top of their license and their skill set, and have really clearly defined roles and responsibilities. Accessible and focused on quality and safety. So sometimes people talk about patient-centered medical home, and they talk about it like it's a project, you know. Oh, and it's Nancy's project or it's Kristen's project. There's a lead on it. It's their project. The project is supposed to be over in a year, so I'll just like kind of hide out, let that wave rush over me. So it's not a project. It's a new way of doing business. You know, it ain't going anywhere. You know, so if your you know, your organization decided to pursue this, then it's a long-term commitment, and it's a process of continually improving and getting better and better until you reach that nirvana of patient-centered medical home. So again, it's not a final destination; it's a model, and once you reach it, that your patients will be receiving care in the right place at the right time, and in a way that really suits their needs. So, okay. So attributes, we've talked about these: patient-centered, comprehensive, coordinated, accessible, committed to quality and safety. Next. So I like to put this from the patient perspective. And so we interviewed patients, and here are some things that they said about, you know, what does patient-centered mean to you? Well, the patient says, we'll recognize that we're the most important part of the care team, and that we are ultimately responsible for our overall health and wellness. So true, right? Sometimes we talk about the care team, but we're not thinking about the patient. The patient should be right in the middle of the care team. They are managing their chronic conditions 24/7. You as a provider might be seeing them a couple of hours a year, you know, if you add it up. So we really need to empower them and teach them to be able to and help them overcome other barriers to be able to manage their conditions. Next one. Comprehensive. So patient would say, provide or help us get the healthcare information and services that we need. So if I have diabetes and I need to see an endocrinologist, you know, it can help me figure out how to access somebody, right? And sometimes that's really hard in a rural area. Got limited specialty providers. Maybe it's telemedicine. Maybe it's consult. Maybe it's, you know, Project Echo that can help teach the primary care provider how to push the envelope and do a little bit more than maybe you were trained to do initially. So it's figuring those things out. Okay, next, coordinated. The patient might say, help us navigate the healthcare system to get the healthcare that we need in a safe and timely way. So in Illinois, we have this primary care case management program where we would give providers a fee for being the coordinator of care. But they didn't know where their patients were. You know, they didn't know where their patients were going. They weren't really the coordinator of care. We thought if we threw money at it, maybe they would be the coordinator of care. But that wasn't the case, you know. They didn't know that their patients were going to the emergency room. But they don't know that their patients are going to the emergency room. How can they coordinate their care? So we figured out ways of hooking up primary care practices and emergency departments to these, you know, electronic feeds, so that every morning the primary what are they doing that for? You know, oh, I didn't even know I had this patient. No, oh, they were assigned to us and we didn't, you know, they were never seen here. Oh, they're just going to get their meds at the ED. Let's reach out to them. Let's bring them in. Let's understand who they are. Let's start that relationship. Let's firmly establish them in primary care. Then we can start coordinating their care, right? Okay, I digress. Okay, the next thing is accessibility. So from the patient's perspective, healthcare team, be there when we need you, you know? So if it's, you know, when I come home from work at 6 o'clock and I realize, oh my gosh, my kid has a fever and they're coughing and they have a sore throat and I don't know if I can come to school tomorrow, but I want to start meds right away and I'm going to go to the ER. So that's not what we want, right? We want to see those people. So are there some extended hours that we can have? I mean, that's one way of doing it. Is there triage that we can provide with, you know, clinical advice? Yeah, I mean, so that's one of the PCMH things, 24/7 clinical advice with a real live person. It's not just saying, you know, go to the ED, we're closed, you know? So it's really pushing the envelope on the way we practice. But that's going to keep people out of it. If you can say, you know what, they might have stress, but, you know, we have an opening in the morning, and or you bring her in, you know, in the morning, and we'll start, you know, start right on. If it's stress. Okay, next thing. Committed to quality and safety. So patient says, please take responsibility for making sure we receive the best possible health care. So, you know, I work in lots of primary care practices, and there's a lot of variation or variability in the way that providers provide care. And we don't want that to be happening. We want everyone to provide the best care, right? So we're going to rely on evidence-based guidelines, and embed them in our EMRs or whatever we have to have decision support, so that when you're at some point with a patient, you're like, should I do this? Should I do that? Let me look at that. Oh, it's just right there. It tells me what to do. So, so we want to be practicing consistently and at the highest quality that we know how to provide. Okay, next. So, what does the patient-centered medical home look like? So I can pop my head up, and you won't have a picture in your head. So what I want to do is contrast it with what a provider-centric medical home looks like, where it's kind of a fee-for-service environment that gets people in and out, and things are convenient for the provider. So I want to start with that, so that you get a sense of what it's kind of a caricature, so don't take offense to this, but it's what, you know, putting the patient, you know, to the side really looks like. And then we'll look at what a patient-centered medical home really looks like. So let's get started. Is that loud enough? it was funny because I showed this yesterday, and everyone was like, "Oh, that was so terrible," and these are all the things that are wrong with it. And there was this one woman who said, "I had a provider who was just like that." I'm like, are you serious? Because that, I kind of showed it as kind of a caricature, right, of all the things that patient-centered medical home isn't, right? It wasn't accessible. What other things that? What other things were going on there that were just really unacceptable?
Not listening to the patient at all.
Yeah, exactly.
Interrupting. Having their own chart.
Yeah.
Eventually. Not being prepared.
Not being prepared. Yeah. So there's a whole team, based in a medical home, right? It's a team-based care. So there's a team behind that provider so that when that provider walks in, they're ready, They have this stuff from the hospital. They know the patient's lab results. They've got what they need to address the patient's needs. So that provider was fumbling around and looked like she's kind of on his own, So any other things that you know? Yeah, right. So accessibility and the appointment. Right, exactly. So this is a really high-risk patient, right? I mean, she was really close to having to have her leg amputated from diabetes because she didn't get the care that she needed. And so open access is one of the things that we talk about in patient-centered medical homes, to make sure that you have at least a few, and this is probably not a problem with yours because you have a lot of no-shows, but that's something we're going to try to work on too. But to make sure that you have same-day appointments available for your high-risk patients with those, patients with urgent needs. So I visited a clinic 2 days ago, and the receptionist said to me, "Well, why would I want to keep appointments open? We're trying to, trying to get in as many people as we can." And I said, "Yeah, well, you can have a full schedule of people who are in for wellness visits, but then you have someone like her who can't get in, right? So you have to make sure you hold some of those appointments for people who really need to be seen now, right?" So, okay. So let's move on and get a sense of, and again, this is far down the road for you guys. First you'll start providing some primary care, then you'll get some. This is what it might look like in Hey, so what do you think of this one? You know what I thought of? I thought of, your primary care practice in the, the health department, and how you actually have a lot of those other services right here. You have this, the diabetic educator, you've got probably have a smoking cessation program, I presume. You have some behavioral health. I mean, that's really amazing. I mean, yesterday actually I was at a primary care practice, and it was just the doc and the MA and the front desk person. It's like, I don't know how we're going to do this. You guys are really set up to succeed in this model, which is great. So what kinds of things did you see here that you like?
Just the obvious as far as, the customer service that they're providing, they're able to take care of people things they want.
Yeah.
Big time and money.
Right. Yeah, so comprehensive and coordinated, right? She's referring, she's getting, more back. Yeah, she saved an amputation, right? I mean, so they were really on top of things, and as soon as she felt like she had something going on with her foot, she came in and they got on top of it. And the other video, that person could have lost their leg. So think about the payment models we were talking about, right? So if you're getting a certain amount per member per month, and so that's hospital, but but what's happening nationally is that primary care is linking with hospitals and specialists, and people are forming accountable care organizations. Everybody's working together because they realize that it's a whole system of care, right? And so, if a person gets their leg amputated, my gosh, that's expensive, right? And it's the tragedy, for the patient, and it's, really it's just a tragedy for the health system. The health system, possibility that, I mean, that happened, it's really unacceptable. So anyway,
I noticed at the beginning of this one too, sounded like there was a relationship building. They wanted her to come in.
yeah, so she got the call, right?
Right.
She wasn't just like trying to get through. Someone called her.
And then when she's in there, there's a relationship about talking more about stress and losing the job. It wasn't just, okay, I'll write your prescription, here you go, out the door you go, you're just one of the herd.
Right.
So,
Right.
that was a little bit.
So you will see these things in the patient-centered medical home framework. So one is, you know, continuity relationship with the provider, so that they get to know you, you get to know them. So you don't have to tell your story every time you go to see a new provider, right? So that's really critical. You get much better care if you have that long-term relationship. The other thing that you pointed out was that she got a call, right? So they were notified that she had been seen in the emergency department, which is something fell, right? So, so they got an alert, and as part of their transition care program from hospital back to primary care, they reached out and they called her. How are you doing? We saw that you were in the, you know, emergency department. Sometimes it's an MA who calls, and there are some red flag questions, and if there are any red flags, like, oh, I got a new prescription, or, you know, I got a new diagnosis or something like that, give a warm handoff to a nurse who then talks to them a little bit more, and maybe they need to be seen sooner than, you know, someone else who may have, you know, been seen in the hospital. So, and maybe you need to do med rec. So yeah, it's reaching out, it's bringing them in. It's
feel like
absolutely good, absolutely. And then you'll see other things in terms of closing care gaps, reaching out to let people know. And I think you do this to some extent now. Probably, do you send a letter when someone's due for a pap smear or a mammogram, or nope?
An initial letter if they get something abnormal in future. Follow up required.
Right. Right. But once you have continuity relationships and you're accountable for the care, for all the care for that patient, that's one thing that, you know, at least if you want to be a patient-centered medical home, that's required, that that there are key things that that you find really important for your particular patients, and you name what those are, and you say, we're going to do outreach and make sure that our patients are getting those things. And it could be paps and mammos, it could be colonoscopy, it could be, you know, lab visits for diabetes, it could be whatever you choose, but that you have a process to reach out to patients, either it's a letter or it's a phone call, whatever, to keep them in the system, to keep them engaged. So, anything else you saw here that you thought was good? Yeah, right. And she was prepared to do that, right? She knew when those classes were. She knew how to access appointments to the behavioral health person. So they had integrated behavioral health. So you have some behavioral health here. You have a counselor. Is that? Yeah. Yeah. So that's amazing. That's great. So they're part of the team. So that provider is really prepared, right? So they got the information from the emergency department. They saw that she'd taken penicillin, that she slipped. I mean, they knew what was going on with her. So, you know, she was prepared in a really significant way. And the fact that she said, you know, you don't need to make a follow-up appointment right now, right? We want to keep our appointments for people who really need to come in. And you're managing pretty well right now. We'll be doing your labs, and we'll see how you're doing. And, you know, maybe she could come in to meet with a care manager and talk about her diet a little bit more, and maybe make a plan for exercise or what have you. So that's another component of patient-centered medical home, that care management piece. You identify the patients that are the riskiest, you know, the most complex, the most expensive, and you put more resources into them to try to help them manage their conditions. So, and you often do that with a care manager, either an RN or sometimes an LPN and MA. Who has particular skills in that and training. So anyway, let's move on to the next one, see what's there. So again, just to recap, fee-for-service payment incentivizes high volume. Come in, you don't get paid for your visit, right? Okay, next, value-based payment incentivizes high-value care to a defined patient population. So this patient population, let's say Kirsten has, I don't know, 1,000 patients attributed to her. She's going to be accountable, and her team is going to be accountable for caring for this patient population. So the individual patients will have a continuity relationship with Kirsten, and then the rest of the team will have tools to engage the rest of the population that's attributed to her and to them in population health management. So they're going to do, they're going to reach out and say, you're due for your pap and your mammo, you're due for whatever. Transition care, meaning I saw that you're in the hospital, I saw that you were in the ED, we'd like you to come in, we want to see what's going on with you. And self-management support. So again, that could be another care team member, like a nurse, who is teaching someone how to better care for themselves to avoid, you know, further health issues down the line. Does that make sense? Okay, great. So again, what does this mean inside the practice? So we're moving from managing schedules to managing populations, right? We're building relationships. So we're empaneling patients. We know who our patient population is, and we have continuity relationships with them as individuals. So, you know, what I'd like to see eventually is for you to be able to say, okay, you know, Kirsten, I have 1,000 patients. I have, you know, 10% of them are diabetic, you know, 5% of them are this. And so you know who they are and what they need so that you can prepare your staff to, you know, to really support you in caring for them. Next one is considering alternatives to the traditional office visit. So this could be group visits. Have you ever done that? Group visits. You know, sometimes, you know, chronic conditions, people have the same thing and they kind of support one another and learn from each other. Diabetes, centering pregnancy. Has anyone ever heard of that? Those are group prenatal visits. It's really amazing. The outcomes are remarkable. So anyway, it's or it could be telehealth, or it could be just phone visits. So if you really don't need to see the patient, why have them come in if they're busy and they have to find someone to give them a ride or whatever it is to make things patient-centered. And but you definitely want to see them when you need to see them, and you have that access available. So monitoring operational and access measures as well as clinical outcomes. So to make sure that your clinical quality measures are good, and that your access is meeting the needs of your patients so that they're not going to the ED. Using teams efficiently. So again, everyone working at the top of their license and skill set. And the last one is building a culture of quality as a long-term driver for practice improvement. So we talked about putting together like kind of a, you know, quality improvement team or committee, or maybe that's your PCMH team, and you know, having a dashboard of your quality metrics. You know, how are we doing in you know, whatever clinical, you know, measures we'd like to look at, and how are we doing in our operational metrics like access and continuity, you know, those kinds of things. You know, and having a dashboard and looking at that regularly and saying, oh, we're doing well on these things, let's maintain those and put them in maintenance, and then everything we're actively working on, we're going to keep up here, and everybody knows what we're working to improve. And, you know, so this is, you know, a great vision, right? And I just wanted you all to kind of see this and get a sense of what it was. It's going to take a long time, you know, and it's something you're going to continue to work on, and it's going to be doing things differently than you do them today. Next year you're going to look different. 2 years from now you're going to look a bit more different. 3 years from now you'll look quite a bit different than you look now. And I want to come back and visit you and see how you're doing in a few years. It's typically about 3 years that people that practice take to become kind of a full patient-centered medical home. But you're starting even further back because you're not even providing the full array of primary care services at this point. And then this whole, you know, rural health center thing, that's a whole other thing that you're, you know, working on at the same time. So there's a lot of work to be done, and but I think you have a really capable team, and I think you'll start identifying things that you want to work on and just, you know, take bite of this big thing and keep moving in that direction. I'm not sure what's next, but patient-centered medical homes are showing results. So this is a kind of a meta study. So they looked at 28 recent peer-reviewed evaluations of patient-centered medical home and found some really nice outcomes in costs and utilization. People using primary care practices more and hospital less. Improvements in quality, so that these practices are getting paid for performance and meeting quality metrics and getting paid for it by their insurance companies. Improvements in access and improvements in satisfaction. So again, how do we get from here to there? So working both on the delivery system and the payment system at the same time, because if you start accepting payment systems that are, like if you were capitated right now, if you got a per member per month thing, you're not ready, right? So we want to work at these things together. We want to make sure that you're ready to accept an alternative payment model to make sure that you do well. And we start with a framework that breaks down the broad concepts that we talked about into an organized structure. So let's do the next one, which I think is the list of standards. So I think your system may use NCQA, which is National Committee for Quality Assurance, but you might use Oregon program. Oregon set up its own patient-centered medical home program, and they're very similar, but NCQA uses these 6 standards to frame this model of care. So again, it's team-based care and practice organization. It's knowing and managing your patients. That's that population health. It's patient-centered access and continuity. It's care management and support for those more complex patients. It's care coordination, making sure the gaps are closed, and care transitions, that you know when they went to the hospital and you're bringing them back to community care. And then performance measurement and quality improvement, that you create a culture of quality improvement, culture of quality, so that you're always working on making improvements in your clinical and organizational quality metrics. So, so that's kind of an overview. Those are the standards. And then these guys who are on this team. So Nancy is your PCMH coordinator, and Kristen is your clinical lead. Yay, champion. And so they both have these the standards and the details in them. And you want to tell them about the assessment that you did?
Yeah, I did. We did 13 pages, and it's a detailed in-depth assessment, and it breaks down 4 concepts into based on these 6 standards, and it really details kind of where we want to focus the way we provide care to our clients. So that's kind of what we're using as our framework to kind of guide us as far as where we're going to start and kind of working to meet those scores and getting to this model. So it was a really in-depth assessment of kind of where we are right now and where we want to go.
Right, exactly. So for team-based care and practice organization, for example, I think there are, I don't know, maybe a dozen, criteria. And so Nancy, for each one of them, would say, yes, we're doing it. And, no, we can't prove it, because we do it, but we don't really have a policy written out anywhere. Or, team-based care, do your clinical team meet together and communicate about the patients that are coming in this morning? Well, we don't really do that. It's the patient huddle. We'd like to do that. So let's identify that as one of our priorities that we want to work on. So we just met for a couple of hours right before this session, and we took that one area of team-based care. We thought, well, that's a good place to start. Let's get our team's head wrapped around this vision about where we want to go down the line. Not tomorrow, but it's down the line. But what can we do tomorrow, to start reaching toward that vision? So, so you set a couple of goals, and one was to really look at the roles and responsibilities of all the team members, right? And say, well, if we wanted to provide more comprehensive primary care, some of those roles might need to change a little bit, right? And we might need to provide some training for folks. We might need to see how they feel about it, right? And we might need to have some standards for how we do some of these new things. And so we're going to be writing policies and procedures and that kind of thing. So, so that was one thing, looking at roles and responsibilities. And the other thing was the team-based care huddle. You know, getting the teams together in the morning and talking about the patients that are coming in, so that the providers can be a little bit more prepared when they go into that room, right? So, so those are two things, the two really important things to start with. So start hearing things about those two things. That's why. Any thoughts on this generally, or any questions, fears? What does this mean for me individually? What does it mean for our patients?
I think it's kind of what I've mentioned before. You know, it's a big shift from where we have practiced in the past. Mm-hmm. So I can imagine there's probably a little bit of fear from staff. Not just fear of change.
Yeah.
To come. You know, and I think one of the biggest fears associated with it is you think it's going to happen overnight, and it's not. And I think that's kind of one of the key things that we need to keep discussing to the team, to the organization is, yes, we're working towards this, but we don't expect it to happen overnight. It's going to be a process, an ongoing process. So to me, that's I think probably the biggest thing that I noticed, or that I kind of gotten some feedback from staff as far as this model is good. How are we going?
Yeah. And hearing for you guys as leaders too, right? Yeah. I mean, like, oh my gosh, I have to facilitate making this happen. And that's why I'm here and Amber is here. And so, we'll support you this year in doing this. And hopefully you'll get to a point where you're kind of on track and can continue on, yourself and rely on each other. So I'm feeling optimistic. I think you guys are really good team. And the fact that you are in a health department that provides, an array of so many other services, I think really sets you up for success. The rural health designation will set you up for better for financial success. So that'll be great. Any other final thoughts, questions? Okay. Look what time it is. I think I've done this before. It's always different though. Anyway, well, it was great to